Good evening to you all, speakers and audience. In the name of the Brazilian Society of Cardiovascular Surgery, me and my colleague Bruno, we will moderate this webinar that brings us an actual and very important theme, the lifetime management of aortic valve patients. I would like to thank all the three speakers, Professor Saadi, Professor Johnston, Professor Jatene, for their presence in this web meeting. They are very important surgeons with large experience in this issue. Just a quick instruction to the audience. In order to organize the final discussion, in this webinar, the chat will be disabled. So all the questions should be addressed to the Q&A question and answer link. Then me and Bruno will direct the question to the specific speaker. So to start, I would like to introduce our first speaker, Professor Eduardo Keller Saadi. Professor Saadi is full professor of cardiovascular surgery at the Federal University of Rio Grande do Sul. He's also head of the Aorta and Structural Heart Disease Center at Hospital Mãe de Deus from Porto Alegre, and he will talk to us about how to make decisions regarding valve therapy. Professor Saadi.
Hi, everybody. First, I'd like to thank the Brazilian Society of Cardiovascular Surgery to Bruno and Carlos Manuel and the Edwards team, for Denise et al. For the invitation to participate in such important discussion with distinguished colleagues and friends, Fabio Jatene and Douglas Johnston. This is a great learning opportunity for me. Here are my conflicts. Conventional surgery with AVR has been used to treat severe aortic stenosis for almost 60 years with excellent results. But there are technological innovations such as sutureless valves and especially TAVR, which in my opinion is one of the most important advances in cardiovascular medicine in the last decades. The preferred access for TAVR is the transfemoral route, as we may discuss later. There is a rapid increase in TAVR volumes all over the world, although SAVR has not decreased as expected. If we consider aortic valve replacement, including root replacement, the volume is almost as same as TAVR, as you can see here in blue, which is all aortic valve surgeries, and in orange, which is TAVR volume. So even in this new era of TAVR, there is still role for aortic valve replacement. Minimally invasive aortic valve replacement, either with a small anterior thoracotomy called RET or a small upper sternotomy, is the contemporary aortic valve surgery, and we can discuss the types of approach later. Here we have a small, like 7 centimeter upper sternotomy, midline sternotomy. These are the alternatives for aortic valve replacement. We've been using more and more biological valves, as we'll see during the presentations. This is an example of a biological tissue valve. Here on your left-hand side, mechanical valves needs anticoagulation with warfarin. The DOACs doesn't work for this type of valves. And warfarin, as you know, is a rat poison and are associated with more bleeding and thrombosis. So biological valves does not require anticoagulation, but has the issues of higher gradients and the problem of structural degeneration. The type of bioprosthesis is important because our current choice has a huge impact on the future therapy. There are some valves. Here you can see all the portfolio of Edwards surgical aortic valves since 1984. This valve is very good, the Carpentier Perimount, And since 2017, we have the Inspiris Resilia that was designed to provide a better alternative for future valve-in-valve. Radiopaque marks and the possibility to increase the size by one number in a future valve-in-valve are some of the features of this valve that will be presented by my colleagues in the sequence. This is a Resilia, small video showing that that there are radiopaque markers. It's a bovine pericardium, and there is a system that you can improve by one size in a future valve-in-valve. Contemporary AVR requires a view of a lifetime management with mechanical valves, in my opinion, restricted to young patients with no contraindications to anticoagulations. Biological valves for most of the patients between 50 or 55 and maybe 75, and TAVR preferred after this age. Patient involvement is also important in the decision making. I strongly recommend this paper by Salaum and Pibarot about structural valve degeneration that includes a very nice analysis of structural valve degeneration of surgical bioprosthesis as well as TAVR valves. These are nicely describes the mechanism of structural valve degeneration, and I'm not going to come into detail. Here are some shown in the top: structural valve degeneration of surgical bioprosthesis, and in the bottom, from here down, from TAVR. And as you can see here, the prevalence of structural valve degeneration is low in midterm follow-up for TAVR as well. In this new classification, he considers not only the hard endpoint, which is the need for another intervention, but more sensitive criteria. Like in stage 1, we have a light morphological disturbance with the valve, such as leaflet thickening, as we can see here in the CT and in the echo, detected by imaging, but with no hemodynamic deterioration. In stage 2, there are more morphological changes in the leaflets detected, as you can see here, but still not very severe hemodynamic dysfunction. Now in stage 3, there are severe morphological changes with leaflet thickening, calcification, as you can see here on the CT and on the echo, and reduced mobility with severe hemodynamic disturbance leading to reintervention. Just stage 3 needs reintervention. Here we can see some predictors of SVD, such as leaflet calcification detected early and insulin resistance that increased by 3 or 4-fold the incidence of SVD that we should understand better in order to delay the generation of biological valves. Today, what we do is just wait and see. The TVT and vivid registry demonstrates that in case of a TAVI valve-in-valve in the future, the risk is even less than a TAVI in a native valve. As you can see here, with a very low 30-day and 1-year mortality, heart failure hospitalization very low, and very low pacemaker rates. Transfemoral TAVR is an alternative. The pros are that is a quick and less invasive operation. There's no need for thoracotomy. You can do it by conscious sedation without general anesthesia, and the recovery is quicker than a conventional surgery. The cons is that aortic regurgitation remains in about at least mild aortic regurgitation in up to 40% of the cases, even with the last generation device. And the incidence of permanent pacemaker is higher, and there's question about valve durability. Rapid deployment or sutureless aortic valve is another alternative for aortic valve substitute. And we can discuss later what is the role in the modern aortic surgery. On the left column here, you have the surgical risk, low from the bottom to prohibitive on the top. And here in this line, you have life expectancy. So the lower the risk and the higher the life expectancy, the more we tend to indicate surgical aortic valve replacement. Long-term durability of TAVR is unknown, but we have some data from registry. This is the UK registry that goes up to 10 years follow-up. And as you can see here, severe structural valve degeneration is very rare, and moderate occurs in a small percentage of patients. With a mean follow-up of 5.8 years, the UK TAVR registry showed less than 0.5% of structural valve degeneration in TAVR valves. The last issue is the possibility of TAVR in TAVR. There is just one paper published very recently, some weeks ago. In this multi-center registry that includes more than 60,000 patients, as you can see here, just 138 needed or required TAVI in TAVI, more than a year after the first procedure for structural valve degeneration. This corresponds to less than 0.22% of the total patients, with good short-term results in terms of low gradient, low incidence of coronary obstruction, and low mortality rate, as you can see here. So, in conclusion, in my view, mechanical valves should be used in patients less than 50 years or maybe 55 with no contraindications for anticoagulation, and of course discussed with the patient the problems of using warfarin for a lifetime. Bioprosthesis should be used in most of the aortic valve replacement surgery, usually between 55 and 80 years, in patients with low or intermediate risk, which represents 60 to 80% of all the patients with critical aortic stenosis. And the possibility of valve-in-valve in the future changed my decision towards to use more bioprosthesis now than we used before. And valve-in-valve TAVR has recently been shown in a registry that is safe. TAVR for inoperable patients, high-risk patients, may be intermediate or now low risk, but elderly, more than 80 or 85 years old. And as I showed in the paper, TAVR in TAVR is a safe procedure. And sutureless, maybe for combined surgery, small aortic annulus, and minimally invasive cardiac surgery. As in all fields of medicine, especially in our area of cardiovascular medicine, a multidisciplinary team involving a clinical cardiologist, the interventionist cardiologist, imaging specialist, especially echo and CT, and cardiovascular surgeon, the preferred approach to offer the patient a personalized medicine with the less possible bias. Thank you very much for your attention.
Thanks, Professor Saadi. Excellent class. Now I will invite Professor Douglas Johnston. Professor Johnston is the Vice President of the Department of Thoracic and Cardiovascular Surgery, also Director of the Thoracic Surgery Program, and Surgical Director of Residence at the Aortic Valve Center of Cleveland Clinic from Ohio, United States. Please, Dr. Johnston.
Thank you very much. Thank you to the organizers for the kind invitation, and best wishes to all of you, all of our friends in the great country of Brazil in this difficult time. It's nice to see everybody remotely, and we look forward to visiting in person again. Thank you for welcoming me to Sao Paulo a couple of years ago, and look forward to discussing the newest developments in valves with you. So I will share my screen. So these are my disclosures. I want to start with a couple of cases because I think that it is very important for us to think, as we just heard from Dr. Saadi, about the real-world applications of this technology. When we look at some of these large trials, what is evident when we look at the inclusion and exclusion criteria is that some of these trials represent a very small portion of the patients we actually see as surgeons and cardiologists. This is a patient of mine who is 53 years old, is newly diagnosed aortic stenosis. He's an executive and is not the healthiest individual, but he's fairly active. He complained of fatigue and had an executive physical where he had an echocardiogram. He has hypertension, which is fairly poorly managed, and had an elevated creatinine and elevated BNP. And here is his echo. You can see a very calcified, immobile valve. He has a very hypertrophic heart, and there is an element of aortic insufficiency as well as aortic stenosis. In these views on the right, I think you can see the severe AI, and in the left, what looks like a bicuspid valve with fairly large annulus. His gradients were in the 80s over 40s, and he has a 27 millimeter annulus by TEE. We routinely get a CT scan on all of these patients, even if they're not considered for TAVR, because in my practice, if you have isolated aortic valve disease, and no coronary disease, no mitral, what we want to know is, does the aorta need to be replaced as well? And is the anatomy suitable to do a minimally invasive approach? So in this case, the ascending aorta was less than 4.5 centimeters. And we can also see the valve morphology looks very much like a bicuspid valve, very severely calcified valve. And we can see in the 3D reconstruction of the CT scan, the location of the valve. And that's also helpful in surgical planning. So maybe we can keep these questions in mind for the discussion later on, but I'm curious whether members of the panel or the audience would think about this patient who's 55 for a standard tissue aortic valve, a mechanical valve, or as some of our colleagues are enthusiastic, even in this age group, a Ross operation, or potentially a transcatheter valve. While it's not, TAVR is not approved in the United States for bicuspid valve, there are certainly centers that would offer this patient a TAVR. So this is the intraoperative TEE. You can see the valve does move, but there's a significant gradient and regurgitation. And this is the approach we use. So I'll just show a brief video of our approach to mini thoracotomy aortic valve. And no, I don't actually operate this fast. This is sped up a little bit. So this is a second interspace incision on the right side. We place a chest tube which is used to deliver the CO2 into the incision, and a soft tissue retractor. And with this, we cannulate the femoral vein percutaneously first, and then once the aorta is exposed, we cannulate the aorta second. So if there's any issue with the aortic cannulation, we can transfuse the blood back via the venous cannula. So this provides an extra degree of care in these cases. The visualization to cannulate the aorta is usually pretty good. And then the remainder of the operation is a relatively standard aortic valve replacement. The view in most cases is pretty reasonable. Here you can see the debridement of the annulus, and then we're putting sutures in using shafted instruments, but in a fairly standard fashion. Sometimes there's a lot of suture in the way of the vision, but other than that, it's a fairly standard operation. And we can put in really any stented tissue prosthesis or mechanical prosthesis. Here we see an Inspiris valve being tied in. It's not necessary to use any adjunctive devices like core knot. In most cases, we can do this operation with hand tie, and then we put a small plate on the rib at the end. So this is the operation that this gentleman had, and here is his result with a postoperative echo with a 27 millimeter Inspiris valve. This is the valve that we took out, so it really was a unicuspid valve with severe calcification, would not have been an ideal valve for TAVR. Now, briefly, before we talk about the overall experience with Inspiris and some of the competing prostheses, I want to mention one other patient because it is also a patient of mine who I did the same operation we just saw with a trifecta valve 2 years previously. She did well initially and then had some mild to moderate aortic insufficiency. So what we would classify as stage 2 structural valve deterioration. So she had measurable hemodynamic changes with insufficiency, but no symptoms. And then suddenly she had an increase in her shortness of breath and fatigue over about 3 months. This was the echo that she had at an outside hospital. So she now has severe aortic insufficiency. And I think you can see on the 3D images here that we really don't see the right coronary leaflet very well. So this looks to me before surgery like potentially a tear of the right coronary leaflet with very severe eccentric insufficiency accounting for her symptoms. So the question in this case always is, should we go for a valve-in-valve TAVI or a reoperation? And in this case, I apologize I don't have the contrast images to show you, but this patient has a relatively small root, and because of the trifecta valve with its tall externally wrapped leaflets, we thought there was a high risk of coronary impingement with TAVI. And so we elected to treat this patient with a reoperation. There's again a view of the preoperative CT. You can see that the posts of the trifecta valve are relatively high and in line with where the coronaries are. So these are really the choices. Should we redo the operation with a different type of valve, like a porcine valve? Should we place a mechanical valve or consider valve-in-valve? And in this case, we thought this was a mechanical complication of the valve and not a tissue reaction on the part of the patient. And so the decision was to replace this valve, and we put in a 23 millimeter Inspiris valve with a good result. You can see here the explanted trifecta prosthesis, and this is clearly a non-calcific structural valve deterioration with a leaflet tear extending from the stent post, which we'll revisit the data for in a moment. So in consideration of these two patients, what I'd like to spend a couple of minutes talking about is what is some of the data of which Dr. Saadi showed us an excellent representation thinking about tissue valve and TAVR. In the US, there is certainly a push to put in more mechanical valves, even in patients in their 50s and 60s. And that is certainly based on a couple of large studies of which we are all familiar. The Goldstone study from the New England Journal is one. These are all large registry studies which showed a better survival with mechanical valve than tissue valve. And an example of one such study is on the right, looking at this obviously is reoperation versus survival. It's no surprise to any of us that tissue valve patients have a higher risk of reoperation, but several studies have suggested better survival for mechanical valves. So we looked at our own population of patients who underwent isolated aortic valve replacement from 1990 to 2016. So 5,800 patients who underwent isolated AVR with tissue or mechanical valve. And we did 3 separate analyses of these patients, a propensity match, a multivariable logistic regression, and then a random forest analysis, which really accounts for some of these age differences in patients, which may impact more than some other factors, the survival. What we found was that the survival out to 18 years is essentially identical if we account for those other factors. Even after reoperation, This is before the valve-in-valve era, so this is for patients needing surgical reoperation. There's no difference in survival before the reoperation, and for those patients who have a reoperation, there's no difference afterward. So at least at the Cleveland Clinic, and we are an institution that is very much pro-biological valve, even in very young patients, we feel that this is a good demonstration that properly managed patients do well, whichever direction they go. The risk of stroke and bleeding is higher with mechanical valves. And for many patients, even the very young patients, 30s and 40s, the lifestyle changes of being on blood thinners are a real issue. The result of that is that 90% of our practice is tissue valve, even in those patients with congenital heart disease who are in their 30s and 40s. We obviously have a very large choice of tissue valves, and Dr. Saadi gave an excellent overview of these. I won't go into more detail, but let's dive a little bit deeper into what makes the Inspiris valve different. As was mentioned, the radio-opaque markers and the unique band around the base of the valve that allows for facilitating future valve-in-valve. But what really interests us for this valve, especially in the younger patient population, is the Resilia tissue. So what makes Resilia different is the fact that the leaflets are not preserved in glutaraldehyde. So that after the initial fixation, the tissue undergoes a stable capping process, which theoretically covers most of the aldehyde areas on the valve that would bind calcium. The early data on this was proven in an animal model that was done by my good friend Bart Murris in Leuven in Belgium, and showed that in a juvenile sheep model, shown on the left, the calcium content in Resilia tissue was reduced by 72% compared with the perimount, which we would consider the gold standard with the longest proven durability out to 30 years. When they looked at gradient after 7 months in the animal model, there was a 29% reduction in gradient. You'll see here that the gradient in the Resilia tissue valves does increase, but these are quickly growing sheep, and so the gradient increases because the cardiac output increases. But the improvement both in calcium and hemodynamics was very impressive. The first human study was a European feasibility study, which when I look at studies like this, the most important thing that I want to see from an early study of a tissue valve is that we don't see any signal for non-calcific structural valve deterioration. So are the leaflets durable and strong? Is there an issue with endocarditis, or is there an issue with thrombosis? So with any new leaflet treatment, that's what we're interested in. And this study showed no cases of structural valve deterioration. This was with mean follow-up of 4 years, so still relatively early, no major paravalvular leaks, and no endocarditis. So showing that this radically new tissue treatment in a human setting is safe. The US trial, which followed up on this, was called the COMMENCE study, and I had the privilege of publishing as first author the paper based on the work of a lot of people across 27 clinical sites in the United States and Europe. This was presented by Dr. Bart Griffith at the AATS last year, and recently published online in the Journal of Thoracic and Cardiovascular Surgery. So almost 700 patients, which were age 18 or older, but there were a fair number of patients under 60 years. The important findings here were that there were no cases of structural valve deterioration early. The transvalvular gradients out to 4 years were low and remained low. And another very important finding was that we did not see any evidence of an increase in transvalvular regurgitation. So what this tells me is that we're not seeing leaflet tears, we're not seeing thrombosis, and we're not seeing an excess of endocarditis or other structural problems. So in reviewing the data, I just want to leave you with a somewhat different story. So for a number of years, we put in a very large number of trifecta aortic valves, and we were very impressed by the hemodynamics at implant, and knowing from our previous experience with bioprosthetic valves that hemodynamics are important for the long-term durability and freedom from heart failure. This is a valve that we have a very large clinical experience in. One of our medical students, Camille Young, presented this data at the STS this year. We did a retrospective analysis of the trifecta implants going back to 2007, and did a propensity match with our perimount data. We had more than 2,000 matched pairs of patients, and we looked at the hemodynamics and reoperation of these two very different design valves. So this is what happens with the hemodynamics, and this gets directly to Dr. Saadi's point about focusing on not only on the endpoint of reoperation, but what does structural valve deterioration look early on? What is stage 1 and stage 2, which is often not reflected in the literature? What we saw was that the CE or perimount valve, which is an earlier generation prosthesis, had higher gradients at implantation, but those gradients were very stable, and we know that these gradients can be stable out to 15 years. The trifecta valve, on the other hand, started out low, but rapidly increased. So by 4 years, the gradients were higher than the perimount, size for size. And this was true across all valve sizes from 19 to 29. In addition, we started to see an increasing prevalence of not only mild and moderate, but severe aortic insufficiency. So these numbers are not high, but thinking about the durability data we just heard about for TAVR, 2.5% with severe AI at 5 years is not a good finding. We then looked at reoperation, and this parallels what we see with the hemodynamics in that the perimount valves, 99% were free of reoperation at 5 years, whereas the same rate for trifecta was only 93%. So this is a statistically significant difference early after implant. Surprisingly, because the trifecta is based on an earlier design, as we all know, much like the MitraFlow, the mode of failure was not primarily leaflet tears like what I showed you before. The mode of failure was primarily calcification. And so this looks to be an issue with the preservation technology of this valve. So obviously calcification is the most common mode of failure of bioprosthetic valves, and we're seeing very early calcification in the trifecta. Lesson learned. This is some data courtesy of Dr. Sunil Ori from Southampton, comparing all of the studies which have looked at trifecta experience compared with Magna Ease. And in general, we're seeing a much higher incidence of structural valve deterioration and reoperation, even by 5 years. So in conclusion, we have to be very careful in looking at a new bioprosthetic valve. We're very enthusiastic about the Inspiris valve and the Resilia technology. And part of that enthusiasm is based on now 4 years of data that shows very good freedom from structural valve deterioration. But it is important that we look at what is the definition of structural valve deterioration when we make these comparisons between valves. And as we go forward with the Inspiris valve, knowing that the predecessor, the perimount and the Magna, has such good durability, we really have to look at the youngest patients, and we're really going to need to look at 5 to 7 years or longer to see the potential benefits of this technology. So I just want to leave you quickly with one last case. This might show a little bit of an extreme application of the technology, but this is a 40-year-old woman who has a history of coarctation repair and was told at another hospital that she had to have a mechanical valve and she couldn't have children. So she came to see us because of the small size of her root and with desire to have a minimally invasive operation and hopefully a tissue valve. So this is her CT scan. She has a relatively normal morphology of the valve and the root, but when we did sizing analysis, you can see that the area is relatively small and the average diameter of the outflow tract is only 18. So this is going to be a challenge to put any normal valve. The root is also relatively small at 22. So for our future discussion, should we go with a mechanical valve? Should we consider in this patient perhaps a Ross? Or should we do some kind of a root enlargement? This patient was not interested in a full sternotomy at all and wanted to have minimally invasive surgery. And so we elected to do a mini thoracotomy approach. And here's our planning CT scan. And this was the operation, a right anterior thoracotomy with microdelnito cardioplegia and a 21 millimeter Inspiris valve, which was a good size match for this relatively small lady. So briefly, this is what it looks like, again, through the thoracotomy approach. We're here putting sutures through the patch of the root enlargement, which is then going to accept the Inspiris valve. And you'll see here the Inspiris valve going into the patient. Looks like a tight fit, which it is with that enlargement, but a good size match for the patient. And then here, closing the patch to complete the root enlargement. I very much appreciate the opportunity to speak with you all about our experience with the Inspiris and with valve disease in general, and look forward to the next presentation and to our discussion.
Thank you, Professor Johnston. We'll move on. The next speaker will be Professor Fabio Jatene. Professor Jatene is full professor of the discipline of cardiovascular surgery at the US Medical School, Director of Cardiovascular Surgery Division of Heart Institute, US Medical School, and Vice President of the Board of Directors of Heart Institute. Professor Jatene will talk about Inspiris real-life experience in Brazil. Professor Jatene, please.
For the introduction, and thank you very much for the invitation to talk about this issue regarding real-life experience in Brazil. I'm sharing my screen. Okay. So this is a real-life experience in Brazil. Hey, Dr. Cosgrove, many years ago, was the chairman from the Cleveland Clinic, said that there are multiple factors influencing surgical volume, including demographics, epidemiology, technology, implementation of new diagnostic and therapeutic techniques, the economy, and finally, innovation. And this can exemplify how we have a lot of different variables influencing in the number and the characteristics of the surgery activity. I divided my presentation in 4 different topics, and I will start by demography and epidemiology. It's very interesting to observe that the prevalence increases from 0.5% of valvular disease in the age group from 18 to 44 years old to 10% for the patients over 75 years old. And we can see here and observe the graphics in red, all valve diseases, mitral and aortic, in yellow, the mitral valve disease, and the gray, the aortic valve disease. After the age from 55 to 64, the increase of the occurrence of the valvular disease. Maybe 10 years ago, they are expecting that the valvular heart disease could be the next cardiac epidemic. The other point about this group of patients is the frailty in these patients. Epidemiological studies have consistently shown that frailty carries a relative risk more than 2 times for mortality and morbidity. And so this group of patients can be have a very special care. The other projection is interesting about in UK about the number of the occurrence of the heart valve disease in the group of patients over 65 years old. It is very interesting that we can observe, even in the future years, that the undiagnosed group of patients probably will be high, even in the future regarding valve disease. Regarding surgery, we can consider that about aortic valve replacement, we have more than 40 years of clinical experience. The prostheses are very reliable. We have predictable and low risk in this group of patients. Long-term results available and survival superior to 95% in the hospitalar evaluation. We have many different types of mechanical and biological valves in this group of patients. And interestingly, we can observe, as Dr. Johnston showed us, that the biological valves are increasing the durability and the absence of structural valve deterioration. Here we can observe this group of patients with different types of prosthesis at 10 years, 96% of valve with no structural deterioration. And this paper from Cleveland Clinic showed us that using perimount valve from Edwards, we observed that the actual estimates for explant for structural valve deterioration at 10 and 20 years were 1.9 at 10 years and 15 at 20 years. So as a very good evolution of these biological tissues. With the occurrence, the introduction of the TAVI, we observed that at the beginning, the TAVI was used for inoperable patients and was growing to high-risk patients, intermediate patients, and now we are talking about the possibility in using some patients with low risk. And what did the surgery to react? Reduction of the surgery aggression, seeking for excellence regarding technical advances, improvement of the results, and technological incorporation. About the aggression of the surgery, we move from the conventional sternotomy to small thoracotomies like a parasternal or a mid-knee sternotomy in order to reduce the aggression of the surgery. The other point is the very good results that were maintained in the last years, year by year. And despite of more diseased patients regarding old patients, the results are keeping in a low mortality. But TAVI was increasing strongly in many different centers. And we observed that despite the TAVI is increasing the use of the valves, standard valves, even in isolated procedures or associated procedures, are keeping with a slight decrease. And we can compare the number of the procedures here with about 6 to 7 years in the past. So the decrease was observed, but not so strong decrease of the procedures, standard procedures. And this is a very interesting slide, demonstration. About in the year of 2007 and 2008, we observed the introduction of the TAVI. Here is. And we observed at this point a decrease from mechanical valves and increase the use of biological valves, probably due to the possibility to use in the future, as Dr. Saadi showed us, the valve-in-valve procedure. And we can observe it very clearly when the number of procedures of TAVI was increasing, the number of mechanical valves was decreasing. This is from a German heart surgery report, probably one of the most advanced countries regarding the use of TAVI. And we observed in these last years the increasing TAVI, but a regular maintenance of the standard operations, a decrease in standard operations, but a slight decrease in this group of patients. And we observed here probably a market proposition observing the increase in TAVI, but a possible increase in standard operations. About our initial experience with Inspiris, we can observe that it's composed by resilient tissue. And resilient tissue is a bovine pericardium tissue transformed by a novel integrity preservation technology. And our experience with this valve, including 25 patients from mean age of 60 years old, 68 were male, and these patients were operated by 3 different surgeons, and I personally operated 70% of them in 7 different hospitals, but in majority of them in Heart Hospital, Syrio Libanese, and Albert Einstein. This is not an experience in the university hospital, but in our private group. The Resilia was recently launched in Brazil in February 2019. In other countries, as Dr. Johnston showed us, they have a midterm follow-up, but unfortunately here we have just an immediate follow-up or very, very, very short follow-up. This valve is stored in dry, and for that is ready to use. It's not necessary to wash the valve in the operating room. Presented a longer durability about the tests, and possibly for in a possibility for expanding the ring, as Dr. Eduardo has showed us in this different type of mechanism that allow the growing of the annulus in order to possibly use it a valve-in-valve in the future. Here we can observe the mechanism of that became possible the enlargement of the annulus for a valve-in-valve procedure. Regarding the operative technique, this is a very similar valve to other biological valves. So the technique is a standard technique for implantation of this valve. No need special training. Despite is a new valve with different technologies, the operative technique is the same. No need to wash this valve because it's a dry and the tissue is preserved without humidity. And the special ring that allow the growing of the annulus isn't possible to notice from outside, from the external appearance of the valve. You have a regular valve, despite to have the mechanism at this point here and here, but you can notice this mechanism during the implantation of the valve. Our experience include 14 patients with aortic stenosis, 7 patients with aortic regurgitation, and 4 patients with previous implantation of another aortic valve as a redo. We had here 7 isolated aortic stenosis and another 7 associated procedures at aneurysm of aortic descending, coronary insufficiency, and other combinations. In this group of patients, 2 aneurysms of ascending aorta, 1 annulo-aortic ectasia, and 4 patients with isolated aortic regurgitation. And in this group, 3 of them are isolated, and 1 presented an endocarditis in a previous aortic prosthesis previously implanted. We had, as a first operation, 84% of the patients, and as a redo, 16% of the patients. We had an isolated aortic valve replacement, 14 patients, in associated procedures, 11 patients. Regarding the prosthesis size, we had 20% of the patients, number 21. 28 of the patients size number 23. 20% of the patients 25, and 28% of the patients size 27. And in one patient, 4%, we implanted 19 prostheses. Isolated, we had 11 patients, associated procedures 10, and redo 3 patients. And here we have the associated procedures are aortic aneurysm repair, another aortic aneurysm repair plus cabbage, aortic aneurysm repair and application of the valsalva sinus, enlargement of the annulus, aortic annulus, cabbage and mitral, and ascending aorta Dacron graft in 3 of them. And here we had 3 redo as isolated, and 1 redo with correction of the abscess. The access of these operations included 48% standard sternotomy, full sternotomy, probably in the most associated procedures, and in 52 mini sternotomy, especially in the isolated patients. About the echocardiographic parameters, pre-operatively and post-operatively, before the discharge of the patient, we observed in the aortic stenotic group an area, a valvular area of 0.8 centimeters square, and the systolic gradient pre-operatively 73 and post-operatively 19. The mean gradient pre-operative 46, and the mean gradient post-operatively before the discharge 9 millimeters. The left ventricular diastolic diameter didn't present any difference, as well the ejection fraction that was the same pre and post-operatively. Our post-operatively results included no mortality in this group of 25 patients. The post-operative length of stay after the surgery ranged from 5 to 27, means 9 days. Post-operative complications in this group of patients included one implantable defibrillator in a patient with a low ejection fraction, and a permanent pacemaker implantation in a patient with a previous AV block. About final considerations, I would like to say that this new technology prosthesis includes longer durability, possibility of expanding the ring in the future in a probably valve-in-valve TAVI procedure, and is easy of preparation. The valve is stored dry and is ready to use. The implantation technique is similar to that of conventional prosthesis. Good short-term clinical and echocardiographic results without mortality. There is no learning curve. It's not necessary a learning curve to implant this valve. No specific training is required. And the similar results in our private group were obtained among 3 different surgeons. And I'm sorry that this is a very initial experience with this valve, and we need to making progress in this field. Thank you.
Thank you. I'd like to thank all professors for joining us today. And on behalf of the Brazilian Society of Cardiovascular Surgery, I'd like to thank Edwards Lifesciences for its outstanding support to make this webinar happen. The questions, please submit questions using the question box directly below the window. The video window, please. This is for the audience. And we'll start asking questions. The first one will be addressed to Dr. Johnston. Dr. Johnston, in patients with small aortic annulus, are you more aggressive about enlarging the root to get a bigger valve, thinking about the possibility of a valve-in-valve procedure? and what the VFit technology would contribute for that?
We certainly are more aggressive with root enlargements in patients, in younger patients for whom valve-in-valve is an option. That being said, I think there are some anatomies that are not suitable. The patient that I presented with the small root was, I think, a borderline indication for a root enlargement and a stented valve. This was very much based on the patient preference. But I think what it has taught us is that for two reasons we want to be very careful about valve size. One is we know that durability and hemodynamics really matter based on the size. And the second is that even with the technology like VFit, if we are putting in a valve that is of marginal size like a 19, if we get that to a 21, accounting for the TAVR, we may still leave the patient with some patient prosthesis mismatch. So I think the goal needs to be to have 0 ppm at the first operation, and that's the best preparation for the valve-in-valve in the future.
Continuing the questions, there is a recurrent question in our chat. In the Commons trial, Dr. Johnston presented encouraging results with the Inspiris bioprosthesis with the resilient tissue, with no case of structural valve deterioration in 4 years, even in patients with a 19 and a 21 millimeters diameter. And also Professor Jatene presented excellent initial results in our Brazilian population, what is very important for us. Our patients really are different from the others. We have younger patients in our population, mainly because of the rheumatic fever prevalence in our country. So, continuing in the anterior question, with the aortic annular enlargement, what are the routine? I would like to all the three speakers respond this answer. What is your personal routine when you enlarge the root, and what is your preference technique to do this procedure? Please, starting with Professor Saadi.
I don't like to use biological valves in size less than 21, unless it's a very small lady. So I prefer to use at least 23. So I always enlarge the annulus with a simple incision going through the non-coronary cusp up to the mitral valve, and then a pericardium patch, and then to put at least a 23 millimeter valve. I don't like to use 21, and I think in the last 10 or 15 years, I haven't used a 19. So this is my personal opinion.
Professor Johnston?
I have a very similar approach. I think 23 is the size that is the best fit for most people, the best, unless they're very obese or very large, gives minimal patient prosthesis mismatch for the average patient. And in most patients, if I do a root enlargement, it is, as Professor Saadi described, it is a Nix technique root enlargement using autologous pericardium. It's not only is it, I think, the safest and easiest at the first operation, but it's the easiest to reoperate on if we do have to do an open reoperation. In extreme cases with very small outflow tracts, I'll do a Kano operation. I probably do 2 or 3 of those a year, so it's not a very common part of the process.
Professor Jatene, please. Okay.
This is the same opinion of mine. I prefer to use valves number 23 or more, or in all patients. In this series, we observed some patients with 21 and 19 valves, but it was a cooperative study with different surgeons and a cooperative series with different surgeons, and so one valve number 19 were used. I prefer to put 23 or more. If the annulus is small, I prefer to enlarge the annulus with a extension of the incision in the aortic root until the mitral valve and putting a pericardial patch. This seems very, very simple to me, and I prefer to use that in order to avoid a mismatch in this group of patients. But despite of these valves, that number 19 and 21, we fortunately observed, Dr. Carlos, that we didn't have a special high gradient in the postoperative period. In this valve number 19, the gradient was 32 systolic gradient before the discharge.
I'd like to ask Dr. Johnston and all the others, Professor Jatene and Professor Saadi, what percentage of young patients would you say in your practice are opting for a tissue valve? And do you think the resilient tissue technology will increase that choice?
I would say that 90% of younger patients in my practice opt for a tissue valve. It's a little bit artificial because many patients come to me or come to Cleveland because they know that we will do that. There are some centers that are still very traditional, and I know I recently took care of a patient who is a rock climbing instructor. I mean, he's very active outdoors, has a risk of injury. He was told to stop working and get a mechanical valve. That's not really a very realistic way to treat patients, I think. So we offered a tissue valve. He's only 32, and we put an Inspiris valve in that situation.
Professor Jatene?
My preference is for use biological valves, except in young men that I use mechanical ones. We are from a school that use a lot of biological valves in women and in middle-aged patients, women.
Professor Saadi?
Yes, I agree. We tend to use more and more biological valves. We keep the mechanical valve for young patients, young males that would adapt their lifestyles to anticoagulation. But the thing I'd like to tell you is that many patients come to our center to do TAVR. And young patients, like 55, 60 years old, low-risk patients, some of them with bicuspid valves that has never been included in trials. And our main, we struggle sometimes to convince them that conventional surgery with a biological valve is better for them than a TAVR in this situation. So answering another question that was asked about the involvement of surgeon in transcatheter valves, I think it's very important that we have run a program with training for surgeons with a transcatheter valve, or work in a real heart team that you can offer the patient all the alternatives. Because if you have just one alternative, the patient will look for another group or another surgeon. As they know I do TAVR, and I recommend for a specific patient a conventional SAVR, they will keep more safe to accept the decision in case I just do one procedure.
Okay, thank you.
We have another recurrent question. Many people from the audience are doing the same question. And I direct the question to the three speakers. When you consider a sutureless prosthesis in small aortic annulus, let's start now with Professor Fabio Jatene, please.
I'm considering in a patient with a very small annulus. And for some reasons, I decided not to enlarge the annulus of this patient. And in this case, I prefer to use, for instance, in 19 annulus, a sutureless valve. My practice during years and years were characterized by enlarged these annulus in a small annulus. But recently we obtained it and we're starting using these sutureless valves. And I confess that at the beginning I had some difficulties regarding the use of these valves as a need of pacemaker, some displacement of the valves. But little by little, I'm using more and more this type of valves, especially in small annulus. I probably will change my practice in order to enlarge less annulus and using more sutureless in very small annulus patients.
Now, Dr. Johnston, please, your considerations.
So I think there are two issues with the sutureless valves in the patients that we're talking about. In an older patient with a small annulus who's having a multi-component procedure, it may be reasonable, I think, to think about a sutureless valve, and we might go down that road as well. For isolated valves, I think the challenge is that most of the patients that I see with isolated aortic valve disease now have somewhat challenging valve problems, meaning that they have unicuspid valve, they have a highly calcified bicuspid, or they have some ascending aortic enlargement. So even sometimes those with a small annulus, and that is less appropriate for a Percival valve. As far as the Intuity goes, I'm just not sure based on the data that you gain much in terms of gradient with the Intuity. It looks good on echo because of the valve skirt underneath the annulus. You don't have turbulence from the sewing or from the pledgets. But I think that when we get in my hands, if it's a patient that truly has a 19 annulus and they're a normal sized patient, in some of those patients, if the annulus is 19, even a root enlargement is not going to give a very satisfactory result because the valve is always a little bit tilted. And I think in those cases, probably the best thing to do is to do either a stentless valve or an allograft or a Ross in that situation. Those are challenging patients. But we have to think not only about the short term, but the possibility for valve-in-valve in the long term.
I agree. I'm just still looking for the group of patients that fits to a sutureless valve. We know exactly when to put surgical bioprosthesis. We know the group of patients that have the most benefits for TAVR, but for sutureless or rapid deployment, I'm not sure. If you're arguing about gradient and the patient is an old patient with a good anatomy, I think TAVR is preferred. So I agree that we should I just use rapid deployment valves with combined procedures, double valve plus coronary, that I'd like to reduce a little bit of the time of operation and reduce the gradient. But I don't think we have enough data on long-term results, durability of sutureless valves. And the patients are informed. They ask for either a biological valve, surgical biological valve, or a TAVR most of the time.
One question from the audience. Dr. Johnston and Dr. Jatene and Dr. Saadi, well, have you been using any type of short-term anticoagulation for the patients who were operated on and received this new tissue valve technology?
Dr. Johnston, please.
No, we don't use any short-term anticoagulation for any aortic bioprosthesis, only mitrals. So three months for mitral, but nothing, just baby aspirin for aortic.
Yeah, we do the same, but I think it's a very good question because in the TAVR trials, we have noticed that both valve, either SAVR and TAVR, there are some patients that have subclinical thrombosis with leaflet thrombosis. That may be some patients that are going to develop early structural valve degeneration. And another issue with the TAVI trials compared to surgery, it's good because we're going to know more about the surgical valves in a 10-year follow-up with imaging, is that the incidence of atrial fibrillation is very high in the surgical group. It goes up to 40%, 40, in the first year. So we don't use anticoagulants as a routine, but if the patient is low risk, we use for 3 months now warfarin. But I think we need more data, and I think the trend will be maybe to anticoagulate the patient with biological valves, at least in the first 3 months. And I'd like to hear the opinion of the other colleagues about this issue.
I personally do not use anticoagulation in aortic valve, biological valve position, but I'm feeling a tendency to use these new anticoagulants in mitral valve, biological mitral valve during 3 months, but not in aortic. I personally do not use anticoagulation in this group of patients.
Okay, thank you, professors.
We have another question from the audience. It's a question from Gustavo Judas for all the presenters. Recent papers show a poor accuracy of valve charts to project mismatch, especially in small number, with a great number of false positive. What do you think? Can we be overestimating this problem? Starting with Professor Saadi.
Yes, Gustavo, I agree. I think this is a main issue, as Dr. Johnston pointed out. I think that the gradient is probably one of the most important factors in structural valve degeneration. This is why I think we should not follow the charts or the apps, and we should try to put the bigger valve in the patient. And as I said, I don't like to use less than 23 valve. This is what we do in our daily practice. But I agree with you.
Please, Dr. Johnston.
I think that it's hard to overestimate the effect of patient prosthesis mismatch. The data would suggest that even a difference in initial mean gradient of 5 to 7 millimeters mercury shows a difference in left ventricular remodeling over the first 2 to 3 years. So the difficulty here is that most of the studies, the patient populations are so variable. We have lots of different body sizes and ages and different valve types in the same studies. And I agree that sometimes the charts are difficult to apply in real life. And every root anatomy is different. So I think if we can look down through the valve and the valve is bigger than the outflow tract, we've done a good job. If we look down through the valve and the outflow tract is bigger than the valve, we probably have not done a good job. That is a very simple way of thinking about it, but I think we have to get in the biggest valve we possibly can, but that matches the patient. Some patients have very small hearts, and it doesn't make any sense to put a 29 valve in a patient with an 18 millimeter outflow tract.
I agree with Dr. Gustavo, and I consider this a very important point. The mismatch and the gradient can help in the deterioration of the valve. As I said previously, I prefer to use the biggest valve that I can put in the annulus, enlarging the annulus when it is impossible. This is my opinion.
Another question from the audience. Over the years, TAVR has been increasing. As surgeon, should we look forward to this technique and start implanting biological valves more for all panelists.
Sorry, Bruno. The end of the question, please. I can understand.
Okay. As surgeons, should we look forward to this technique and start implanting biological valves more? Over the years, TAVR has been increasing.
No, I can start with this answer. I showed in one of my slides that immediately after the starting using of TAVI, it was an increase in the use of biological valves. And probably this can be done because of the possibility to put a valve in valve inside. So the combination of a more durable valves and the possibility to put another valve in valve by TAVI inside this first prosthesis can probably make around 30 years or a little bit more in these patients with one operation. And so I understood that probably the increase of the use of biological valves was done to TAVI, the introduction of TAVI.
Okay, thank you, Professor Jatene. Professor Johnston?
So the good news is that, as Professor Jatene said, the valves are getting better. Durability is already very good. If you look at our perimount data that was presented by the other speakers today, the durability at 20 years of the perimount 2700 valve is very good. We've seen patients even in their 50s who received a valve in their 40s or 50s who've gotten 15, 17, 20 years out of those valves. I hope certainly that the Inspiris will even be better. But even if valve-in-valve TAVI turns out not to be good, let's say that the durability turns out much worse than we think, a surgical reoperation and another bioprosthesis is a very reasonable option for a lot of patients. So if patients want to avoid anticoagulation, I view our duty as being as friendly as possible to the patient's lifestyle. So if the patient doesn't want to take Coumadin, I don't think there's any evidence with modern practice that you all are doing that we need to commit the patient to a mechanical valve. If valve-in-valve TAVI turns out to be great, that's an amazing addition to our practice. If it doesn't, we can still do another operation, either with a tissue valve or a mechanical valve, and we can do that very safely.
Thank you, Professor Johnston. Professor Saadi?
Yeah, so I agree. The good thing is that the biological valves are lasting more. It's very easy to put a valve-in-valve, the TAVR in a biological valve, and reoperation of a biological valve is not an issue. The bad news is that many patients are getting TAVR at a young age, and these patients are going to need maybe one or more than one procedures. And surgical procedures in the TAVR patients can be tricky. Depending on the valve that you use, you may sometimes need to replace the root, and you have to have trained and experienced surgeons in the future to do these operations. So I'm a bit worried with this spread of TAVR for younger patients, although there are some very small and recent evidence that TAVR in TAVR is safe, but you push too much to younger patients, you may have to do a very big operations later on in life with the patient older, like in their 80s.
Okay, thank you, Professor Saadi.
Okay, we have a question from the organization directed to all the three speakers. What are your personal percentage of minimally invasive in first aortic valve replacement? And if you use the minimally invasive technique in redo patients? Starting with Dr. Johnston, please.
So in isolated primary aortic valve, about 95% of mine are minimally invasive. Most of those would be thoracotomy. If there's some calcium in the ascending aorta or the root, or it just looks a little funny, then I will do a mini sternotomy because it's easier to convert and the exposure is a little better. many of those patients, the young patients, need concomitant aortic surgery, and so they will get a mini sternotomy from me. I think the other question was, do we do minimally invasive reoperation? I would say very rarely. I've seen some series of minimally invasive reoperations with reasonably good results, but I don't think they're as good in terms of morbidity and mortality as can be achieved with a sternotomy. And that has to be the priority. So in rare cases, yes, but most of the time for reoperation, it's a sternotomy in our practice.
Saadi?
Reoperations, no, minimally invasive, safety first. And overall, I prefer to use an upper midline, small midline sternotomy. And as Dr. Johnston pointed out, there are several patients that need aortic ascending aorta repair that you still can do very well by the midline sternotomy. And I don't have experience with right anterior thoracotomy. And many patients here in Brazil are from the public system, and so we don't have access to videos and some instruments that we need to do minimally invasive surgery.
Professor Jatene.
Yes, regarding the first operation, I try to do as the majority of my patient about the use of minimally invasive, but I prefer to use minimally mini sternotomy. I'm not very confident. I have no practice with the possibility to use parasternal minimally incision as Dr. Johnston showed us. I prefer to use as a partial mini sternotomy. That's a very, very safe, very easy for me. Is absolutely no problem, and I try to use as much as can. In reoperation, I prefer not to use, except one case when I arrived in the operating room, my assistant was prepared and said, no, it's easy, it's okay. It's a very easy dissection, but if I can choose, I prefer not to use in reoperation. So first operation as much as I can. In reoperation, no.
Okay, unfortunately, we have to finish. This was a wonderful webinar. All the three presentations were excellent. I would like to thank Eduardo Lifesciences for the support to this webinar. I would like to thank our president of the Brazilian Society, Eduardo Rocha, for the organization, and also our educational director, Dr. Rui Almeida. We thank all the three speakers for the excellent presentations and the exceptional discussion that we have in this final session. Bruno, please.
Thank you for all panelists. On behalf of the Brazilian Society of Cardiovascular Surgery, I'd like to thank the audience for participating, and thank you very much.
Thank you.
Thank you.
Thank
Bye.
you.
Be safe.
For you all.